Very glad and honored to present to you Professor Daniel Cohen. He received his MD degree from Tel Aviv University. He served in the Israeli Defense Army as the head of the Infectious Disease Unit, and he joined Tel Aviv University in 2002, and as from 2007, he served as the chairman of the Department of Epidemiology and Preventive Medicine. Professor Cohen.
Thank you very much. Just a very little correction. PhD and not an MD.
What did I say? PhD?
No, MD. But you know, I invite the MDs. But I'm yeah. Thanks. Thank you very much. Okay. I'm glad to take part in this symposium, and it's. I'm glad and honored to take part in this symposium, and it's not a very easy job to give my lecture after so fascinating previous lectures. But I'd like to keep my lecture and with the theme of this symposium, and give and review some examples of accomplishments and also challenges in prevention of infectious diseases in Israel. And I dare to say that Israel is a developed country. And that's why the relative importance of infectious diseases as a cause of death is low, as it is, and it is similar to what's happening in other developed countries, like those belonging to OECD. Nevertheless, Israel has a lot of morbidity related to infectious diseases. There is a burden, economic burden, due to infectious diseases. And Israel is at risk, as other countries, by maybe more, in relation or when we speak about emerging infectious diseases, when we speak of bioterrorism, for example. Israel has a solid passive surveillance system of notifiable diseases, periodically updated and enhanced, and through the ICDC and the Ministry of Health has developed a multi-layer surveillance network for rapid detection and management of unusual morbidity, with a dual scope of responding quickly and efficiently to the threat of both emerging infectious diseases naturally occurring and bioterrorism threats. And these multi-layers include syndromic and laboratory-based surveillance, integration of clinical and laboratory data at community and hospital levels, medical centers and HMOs, emergency department data, mortality data. These are usually and often combined and integrated to have temporal and spatial analysis, and to model and to have risk assessments. Israel has also an advanced national immunization program with a 93 to 94% vaccination coverage. And this brought to a significant reduction in the incidence rate of vaccine-preventable diseases. And there are a lot of examples which are also very common to other developed countries with a good national vaccination program. But I'll take just the example of hepatitis A and the introduction of hepatitis A vaccination, universal vaccination in 1999. Israel was a country of intermediate to high endemicity of hepatitis A, with about 50 cases per 100,000 citizens per year, and the introduction of vaccination, and Israel was the first country all over the world to introduce routine vaccination against hepatitis A. The introduction of 2 doses of hepatitis A vaccine in 1999 had a tremendous impact on the reduction of the incidence of this disease, and today we actually witness an incidence rate of about 1 case per 100,000 people per year, which is very low, and it is even surprising in terms of effectiveness of this vaccine. And this is probably related not only to protection conferred to those who are directly vaccinated, but also to a herd immunity effect that this vaccine had in the population in limiting the circulation of the virus, especially in infants. And this is very nicely documented by the comparison of the seropositivity to hepatitis A antigen before the introduction of mass vaccination and after the introduction of mass vaccination, with a significant reduction for about 20% seropositivity or seroprevalence of IgG antibodies to hepatitis A to a very low prevalence rate. And these are data coming from the South on the population that you've heard about, that Professor Bellmaker cited and mentioned, the Bedouins in the South. And in the last years, we have an additional and important accomplishment of the introduction, recent introduction of new vaccines, and we can say that we are in the front of those who adopt a new vaccination, introduce them in the routine vaccination program, and the examples are varicella zoster vaccine in 2008, pneumococcus septa, and now 13-valent vaccine, the rotavirus vaccine, and in a few months from now, the human papilloma vaccine. I'll take just the example of rotavirus vaccine, the introduction of this vaccine, and what is so far the impact of the introduction of this vaccine. And just a few words, you may know that rotavirus is the most common cause of severe diarrhea in infants, and all over the world. It's a democratic disease, affecting, in terms of morbidity, both developed and developing countries. But if we speak of mortality, 85% of more than 500,000 cases or death related to rotavirus all over the world occur in developing countries. And in developed countries and in Israel, for example, rotavirus is and was suspected to be related, associated with a very important and high economic burden. And there was a breakthrough in prevention of rotavirus all over the world with the licensure of the 2 live attenuated rotavirus vaccines, Rotarix and Rotatec, in 2006. And since 2007, partial vaccination of children in Israel started based on private purchase of the vaccine. And we actually wanted to know around 2006 and 2007 to quantify the impact of the burden of rotavirus infections and those especially associated with hospitalizations in children less than 5 years of age. We started with this prospective study including and involving 3 hospitals in northern Israel, and that was in parallel with a very nice study run in the south by Ron Dagan and his group. And the idea was to, first of all, to bring data, quantitative data of the burden, and to help the decision makers to know if it is indeed worth to introduce the rotavirus universal vaccination. And that on the background of the beginning of vaccination, private vaccination, which actually turned this democratic disease to a less democratic disease, because those who could purchase the vaccine were those who could afford. So we got the first quantitative data on the burden of rotavirus, and we also wanted to have actually baseline data in the case that we'll introduce the vaccine to know and to be able to quantify the impact of the introduction of universal vaccination against rotavirus. And just to give you we could actually attain incidence data because we had denominators, and then we translated these incidence data into burden, and altogether we actually found out that about 4,000 hospitalizations in children less than 5 years of age were associated with rotavirus. And this was about almost 6.5 to 7% of all his hospitalizations occurring in children less than 5 years of age. And now let us look at what happened after the introduction of the vaccine by a few criteria. First of all, we speak about the relative importance of rotavirus as an etiologic agent of diarrhea associated with hospitalization, and we see already that there is a significant decrease in the isolation or detection rate of rotavirus after the introduction of the infant immunization against rotavirus. And if we look at the cumulative number of cases of rotavirus gastroenteritis associated with hospitalization, and we look at the different curves in the years that we followed up, so we found out that in infants, after 2 years of introduction of the vaccine, there is a very nice decrease, and the number of cases are the lowest. The same even in the whole less than 5 years age group, where rotavirus has probably also already shows the rotavirus vaccine an effect and herd immunity effect. And these are data of visits to family physicians in the community. Our data coming from an HMO from Maccabi Health Services, and there is a nice reduction of visits due to in the community, visits to physicians due to rotavirus in infants, and especially, of course, in winter, where probably most of the morbidity is related to rotavirus. These are actually just visits with diarrhea without having a clear definition, but probably most of them are related to rotavirus. So altogether, we can now very cautiously, because we have only 1.5 years of follow-up after vaccination, introduction of the universal vaccination, so we can speak about a reduction of about 50%, 40 to 50% in the incidence rate. And if we take hospitalizations, there is already a significant decrease in hospitalizations due to rotavirus in the 0 to 5 age group. Now we go and start to speak a little bit of challenges, and I'll give 2 examples, and there are a lot of challenges, of course. I'll limit myself still to children. I won't speak about nosocomial infections, which is a problem of all the developed society, about antibiotic resistance. Just keep with this pediatric population, and speaking a little bit on infectious diseases, vaccine preventable, and not still vaccine preventable in this population. The first example will be mumps. Although, altogether, I'd like to speak about the re-emergence of vaccine-preventable diseases, and here we can put together the onset of outbreaks of measles, after measles was thought to be eliminated, outbreaks of mumps, outbreaks of pertussis, after the introduction of acellular pertussis. So there are a lot of problems all over the world, but let's take some examples from Israel, and this is the epidemiological curve of mumps in Israel. And after the introduction of the second dose, the 2 doses of MMR, including the mumps vaccine, there was a very nice reduction and almost no cases of mumps for years. And here we come to 2009, 2010, and an outbreak, a huge or large outbreak, huge or large in terms of Israel, outbreak of mumps occurred in Israel. And it turned out that most of the cases that occurred, this is the epidemic curve, okay, and most of the cases occurred in Jerusalem district and also in Tel Aviv district, but especially in Bnei Brak. And altogether, we found out that the highest attack rate occurred in teenagers and in yeshiva students in Jerusalem or in Bnei Brak. And interestingly, in Israel, and also you will see in all over the world, a lot of morbidity occurred even in those who received 2 doses of MMR, including, of course, the mumps component. And this is on the basis of let's say, more than 90% coverage in the whole Israeli population, and much higher coverage in Israeli Arabs, who represent about 20% of the population. And in cases, we also saw that the very small percentage of cases of mumps in this outbreak occurred in the Arab population. We ran actually seroprevalence or seroepidemiological study in these populations in Bnei Brak and in Jerusalem using archived sera, and we ran this study on sera collected before the onset of these outbreaks. And we could see that actually in Bnei Brak, in Jerusalem, and in Bnei Brak, the seropositivity, well, this is an important slide, but it will come later. Okay, that in Bnei Brak, in Jerusalem and in Bnei Brak, the seropositivity rate was much less than that of the general population, and much lower at around 50%, 55%, 50%, much lower than the threshold of immunity in the population needed to assure herd immunity and prevent the occurrence and onset of outbreaks. So this is one explanation. And we also found out a little bit later that a very similar outbreak occurred in a very similar, I could say, a sister community in the United States, in New York, also Orthodox Jewish community. If you look at the abstract of this paper published in the New England Journal of Medicine, you will see so many similarities with what we had actually in our case, including the high coverage, actually relatively high coverage of 2 doses of the mumps, the MMR and mumps vaccine, and still the occurrence of this outbreak. If I summarize, and I'll take and I'll categorize the risk factors or the factors which were responsible to or related, associated with the onset of these outbreaks, I would relate them first of all to the vaccine. These are vaccine-related factors because we know that the mumps component in MMR is less immunogenic, for example, than the measles component, and in the circumstances, under circumstances of outbreaks, the effectiveness of mumps vaccination is much lower. There are studies showing waning immunity in both concentration of anti-mumps antibodies and also avidity of antibodies to the mumps component. And interestingly, there was no no entire cross-reactivity between the strains, the outbreak strains, the G strains isolated in Israel and in the United States, the same, by the way, the same strain with the vaccine strain, the Gerilin vaccine strain used in both circumstances. And there are some population-related risk factors, and we speak about lower compliance in these pockets of populations in Israel, in the States, and other places all over the world due to delay or refusal to take the MMR vaccine. And these probably brought the gaps in the population immunity, which we documented in SIRA taken before the onset of the outbreaks, and this comes together with a very, very important risk factor, which is the overcrowding conditions in these populations, and this together is actually probably the trigger of these large outbreaks occurring in teenagers. Now let us take the last example, and this example will be related to a disease which has no licensed vaccine so far, and this is Shigellosis. And we are and witnessed actually in Israel a very interesting appearance of cyclic epidemics of Shigellosis. And what I can say is, despite the fact that Israel is we agreed, a developed country, Shigellosis is highly endemic in Israel, with a mean incidence of about 80 cases of culture-proven cases per 100,000 per year. Of course, underestimation, because we speak about culture-proven cases reported to the Ministry of Health, and this is about 10 to 20 times higher than the incidence in the United States. And children and soldiers serving under field conditions, children aged 1-4, are at an increased risk to Shigellosis. And this is the epidemiological curve of Shigellosis based on passive surveillance, the Ministry of Health, without actually mentioning what is the serogroup of Shigellosis. So altogether, we can actually identify these every 2-year cycles of Shigellosis, okay, in the last 15 years. We established at the Israel Center for Disease Control a sentinel-based surveillance system network on endemic diseases, including Shigellosis, where actually we combine data coming from the cases, clinical data, with the in-depth characterization of the organism. And of course, primarily confirmation and identification reveals the serogroups, the 4 serogroups, and the relative importance of the serogroups of Shigella. And we can see here that Shigella sonnei is actually almost entirely responsible for these cycles of Shigellosis occurring in Israel, in the general population. When we look just a minute or a second to what's happening in the 20% of the population, the Israeli Arabs, we can see that the picture is different, and here the leading Shigella organism is Shigella flexneri. And if we look actually at the age distribution, we find indeed that these cyclic outbreaks occur in the age group 0 to 4, much higher than in other age groups. And if we speak a little bit about the characteristics of these outbreaks, and we have a lot of data, more than 26,000 culture-proven cases between 1998 and 2010. These cyclic outbreaks are winter outbreaks, winter epidemics, are propagated antibodies, propagated outbreaks, probably due to person-to-person transmission of a very low infectious dose that Shigella needs in order to cause disease. They occur primarily in Jewish Orthodox communities, highly crowded, with highest number of children per household, but otherwise with very good sanitation and infrastructure. So we are not here, we don't speak about what we heard in the previous lectures, developing countries with bad sanitation, with a lot of risk for diarrheal diseases. So we speak about communities, and you will see, for example, this is just an image of one of these communities, very nice, even new buildings, and good infrastructure, flushing toilets. You know, these are towns of established about 15 years ago, 20 years ago. But the problem, or the two important characteristics, are these. First of all, if we look at the age distribution of the population in a town which is affected by these epidemic cycles, you can see the very large base of the pyramid, which means a lot of kids, age 05, 04, as compared to the same district, but without this town, where the pyramid looks like, you know, a pyramid with a regular developed distribution of the population. And if we look at the number of persons per household, about 25% of these households have more than 7 members. And again, a lot, if we combine the two figures, a lot of kids in the age group 04, a lot of kids going to kindergartens, a lot of kids having or changing their defecation habits from diapers to independent defecation. And you know that there is a lot of exposure to fecal material. And again, Shigella is transmitted very, very easily, very low infectious dose. So these are very significant risk factors. And we characterized a little bit these isolates in a collaboration with current and recent collaboration with the Sanger Institute in Cambridge. And we ran the whole genome sequencing of these isolates, and we found out that actually here, these are the kids. These are the kids in these communities, and we see that there is a combination or coexistence of different clones or different clades, and from time to time there is an emergence of one of these clades, especially in the epidemic years. There is not just one clone, but a few clones that from time to time they are maintained, but from time to time there is an emergent one, and this is different with what we were used to see in the 90s, 80s, 90s, when Shigellosis was very common at a very high attack rates in the army, where most of the transmission was common source transmission, point source transmission, foodborne or even fly-borne transmission of Shigella, and this is how it translates into specific clades. And if we look here, we have also some isolates from actually Arab children from the south, and they are different, at least different to what we see of Shigella sonnei, what we see among these Jewish communities where these outbreaks occur. And if we raise the hypothesis why these cyclic outbreaks occur, so we can think back to what happened to measles and mumps, but especially measles years ago, before the introduction of MMR or the first measles vaccine. There were these cyclic outbreaks occurring, and we think that occurring to changes in the immunity of the population, the increase, decrease of herd immunity, the intake of, or the occurrence of new cohorts of newborns. And in relation to shigellosis, we think that we deal with a similar phenomenon. Of course, there are differences in the R0 and in the fact that measles immunizes for all life. But here we think that this morbidity is due to changes in the level of natural immunity. An outbreak occurs, there is an increase in the level of natural immunity to Shigella sonnei and herd immunity. 1-2 years later, there is a decay in antibodies. We know that this from studying the dynamic of IgG anti-LPS Shigella antibodies. There is an intake of newborns in this community, so there is a decrease, new susceptibles, and again, under the main risk factor of crowding, of continuous exposure. The human reservoir of Shigella is continuous. It doesn't disappear, okay? But when the immunity goes down, this is the time that a new outbreak will occur. And what do we know? We know that natural Shigella infection induces protection, but again, it's not like measles. That's not lifelong protection. Protection is about 70%. It's of unknown duration, and there were several publications, and this serotype specific. Sonnei will protect against sonnei, not against flexneri. And what we know from our studies, looking at the relative risk of developing shigellosis, of Shigella sonnei shigellosis of those who were exposed and developed the disease in a previous outbreaks, what will happen to them in a second outbreak 2 years later, we know that the disease confers about 70 to 80% protective efficacy. We know that this is related to a significant higher level of serum antibodies to LPS in following the epidemic versus non-epidemic years in the same population. And we know from other studies carried out in the 80s, late 80s and 90s, that these antibodies are well correlated with protection. And actually these were the basic findings and data which served the basis for the development by John Robbins at NIH of the conjugate vaccines against Shigella. So we think that this protection is related to the level of anti-Shigella antibodies. And again, I will like to bring this data coming again from our sister communities in New York. And here you can see these are curves kindly provided by Sharon Bolter from the New York Department of Health. And here, if you look at Shigellosis in these communities, you can see these cycles, okay, albeit sometimes longer breaks between cycles. And this is New York, all New York. So all New York contributes very little, but still maintains the reservoir between these outbreaks. We think and we know that there may be overseas transmission of Shigella sonnei between these communities because there are a lot of relatives traveling from here and there. But we don't think that, like with measles, you need an index case to cause an outbreak. Here, you have the reservoir at home in Israel or in the States, and it will take, and the same immunological phenomenon will occur here, will occur there, in order to that these outbreaks should occur. And we are trying to address and to try to tackle this interesting, but also concerning re-emergence or these cycles of disease. We try to better understand the immunological subjects by immunomonitoring the cases occurring in Israel. We are part of a European consortium looking at natural infection, learning from natural infection towards development of Shigella vaccines, and it may be possible that such a vaccine will be important. Of course, we have to do our best with all the conventional interventions to try, and it should start actually to just washing hands, but it is not so easy, okay? It is really not so easy, and we have flushing toilets, we have everything, but crowding, and a lot of children at this age, they are coming together in a synergistic risk effect. I may say that these are challenges, and these are challenges that can be taken together. This is actually our setup with which we try to learn more on the disease occurring in Israel, combining research efforts in my lab and also with those of colleagues in medical centers and also in the community to learn more and to try to be ready to do better interventions. But if I may come back to this statement, and this will be the last one, I think that this is a challenge that I'd like to have your opinion, how we can, in the States, in Israel, these are communities where we are responsible. They are part of our country, part of our people. It's important to solve the problem there, but also to solve the problem or to help decreasing the problems that may occur in the general population. We speak of mumps, we speak about measles, and if we speak about shigellosis. Thank you.